Well, hello and welcome. This is Carol Allingham's lecture on advanced directives and some other matters regarding patients' decision making and end-of-life decisions. Now, I know you're very disappointed because we have finished all of our HIPAA lectures in this class, and I know how much you love those HIPAA lectures, but I'm sorry to tell you, we have to get off the HIPAA train at this point and move on. So today we're going to talk about advanced directives. So you should have some handouts in front of you. One should be, it's actually a sheet of paper and it's from the Pennsylvania Bar Association. It's actually a pamphlet when it's folded up, and it's entitled Advanced Directive, Advanced Healthcare Declaration, Living Will. And this is what I regard as the short form of advanced directive. You should also have a packet in front of you entitled The Durable Healthcare Power of Attorney and Healthcare Treatment Instructions. This is kind of the long form, and don't be intimidated. We're going to walk through them once we get through the pamphlet. The packet's going to be a piece of cake. And finally, points to remember for advanced directives. That would be your third handout. And that's all you need for this lecture right now. If you have anything else, set it aside for now, and that will be on another video. Okay, let's look at some terms that you want to highlight on your points to remember sheet so that you are ready for exam number 2. Brain death, death, healthcare power of attorney, living will, euthanasia, and assisted suicide. These will be on the test. You do not have to memorize the definitions. You should be familiar with what they mean. You're going to need to know them in your profession, but you do not have to memorize the verbatim definitions. And remember, it is an open notes, open book test. But you'll be more efficient as a test taker if you have these items highlighted. Before we get into the technicalities of advanced directives and the laws that regulate those issues, I'd like to talk about just death. Death is a loaded word in our society, and it's different for every person, of course. You are going to be in a position where it is very probable that you will at some point deal with people or persons who are dying. We kind of all do it. It's kind of a fact of life, but people, especially in our country, have a lot of apprehension about death. We live in a culture that focuses on youth and beauty, and we get our faces fixed as we get older. It's kind of a rite of passage in our culture, but that is not shared by other cultures in the world. And in our country, we have a lot of people from many, many different cultures. So I want you to be comfortable with that knowledge and with people who are facing the end stage of their lives, because you are the person in the doctor's office to whom they will be looking sometimes for comfort. Does that mean you have to comfort them by saying nice things and patting them on the back or whatever? No, that doesn't mean that. But if you are comfortable with the idea of death and dying, then that's going to be palpable. They'll be able to feel that when they come into the office. You're the person who's going to be doing the hands-on things, the taking of the temperature, the respirations, the pulse, the blood pressure, helping them into their gown if they need help with that. You're the person who's going to spend the most time with the patient. So I want you to convey confidence and comfort to the patients just by the way that you are. And you'll do this without even trying, as long as you are comfortable with the idea of death, as much as you possibly can be. because of course, I don't know your background, your cultural expectations, or your thoughts about death. So I found this neat article on the internet, and it is entitled, would you believe, Confessions of a Funeral Director, Working at the Crossroads of This World and the Next. Okay, so, and it is credited at the bottom of each of the screens there that I used his information from. So this gentleman, his name is Caleb Wild, and he is a funeral director, and he reviews 5 major cultural attitudes towards death that he encounters in his work. The first one is that of a tame death. In a person who believes in a tame death, death is familiar and simple. That is, it's regarded as inevitable, and no attempt is made to evade it. Persons who are dying typically calmly await their deaths, usually surrounded by loved ones and members of the community, all of whom wait peacefully for the end. In other words, death is something of a public event, a major focus of attention in the community. It's deeply affected by the loss of one of its necessary participants. So people are there, they're present. People are comforted and being comforted and comforting the dying one. Death is seen as a sort of a sleep. Either one is awakened at some point to eternal bliss, or one remains eternally asleep. So this is the tame death belief about death. And I worked many years as a home health nurse, visiting nurse, and I have seen these kind of deaths. In fact, I've seen more of these kind of deaths than the unpleasant kinds of death, the ones where people are denying their death. I've seen very few of those in 18 years of full-time nursing. Most of the deaths that I had seen are the tame deaths. People are realizing that their time is coming close and they're spending it with friends and family and others in the community. The next type of conception of death is death of the self. And in death of the self, the focus of the attention is on the one who dies. Now, death produces a great anxiety in the person dying because it's believed that one is either rewarded or punished in his or her future state. So it would tie in with what your belief system is in terms of your religion. Death of the self involves a final testing period, and what one does at the moment of death determines what will happen to one after death, and indeed the meaning of a person's whole life. So several religious traditions have this type of belief. For instance, some Jewish people believe that it's important at the moment of death to recite the Shema, S-H-E-M-A. Muslims are taught that invoking the divine name at the moment of death can save a person. Salvific is the word they use. And some Buddhists hold that the chanting the name of the Amitabha Buddha at this point in one's life will ensure that one will end up in the pure land, capital P, capital L, pure land after death. In the West, in the Western Hemisphere, Western culture, this attitude once led to development of a formal ars moriendi, an art of dying well. So that is the death of the self. Next cultural attitude towards death is that death is a remote and imminent event. The person's attitudes towards death is basically highly ambivalent. Not so sure if you want to go there, not so sure that you don't. Death is viewed as a wholly natural event. It's not a supernatural event in this belief system, but still great effort is made to keep it at a distance. It's both natural and dangerous, inviting and repelling, beautiful and to be feared. So that is the remote and imminent death. There is the death of the other, not finally, because there are 5 of these cultural attitudes. So number 4 is death of the other. And here the main focus of attention is on the survivors. Death primarily involves the breaking of relationships. For survivors, it results in an intolerable separation from the one who dies. I think of this type of attitude as the type of attitude that we have when a child dies. You never really get over that. And we lost that child. And as that child would have grown up, we would think, okay, now he would be in first grade. Now he would be in second grade. Now he would be graduating high school. You never really lose that feeling of connection to that child who's passed away. But anyway, this isn't just about children. This is about any individual who passes away. So the feeling and behaviors may go nearly out of control, like wailing, keening, throwing oneself on the grave. And I have seen these and heard of these in children's funerals. For the one who dies, death is primarily a period of waiting to be rejoined with loved ones in some other state. And the final cultural systemic belief about death is death denied, or the so-called forbidden death. And death is seen as being dirty or indecent, even pornographic. So it's offensive to die in public. Dying persons are therefore more or less isolated from the rest of the community. The very fact that a person is dying is denied. You just don't admit it. You just don't talk about it, you don't admit it. Both to the person, to the patient, him or herself, and to those around him or her. So emotions, both before and after death, are hidden. And mourning is seen as like a pathology. They avoid the mourning person who's trying to get over the death of a loved one. I see some of this in America. I see this because people say, well, I don't know what to say to her, so I'm not going to call her. If there's somebody who's been had the death of a spouse, is usually what I have seen. I just don't know what to say, so I'm not going to call. Well, the fact is, just the fact that you call and say hello means something, because there is no magic thing to say. But excuse me, I think people use that as an excuse to not have to deal with the discomfort of someone who has lost someone close to them. So I wanted to review these with you and just have you be aware that one of the first things you're going to say to a new patient coming into your practice or coming into your facility is, do you have an advance directive? Because you need to have a copy of that advance directive on the medical record, in this hopefully on the EHR. When you're asking that question, you may have some odd responses, and just understand that it's more of a complex issue than just a document. When you're asking, do you have an advance directive? Oh, yes or no. If they give you a simple answer, that's wonderful. I think what they usually do is, if they don't have one, you give them a brochure or something. And you're going to follow the policy of your employer when you get a job, because they're going to have a policy about it. But I will tell you, you are going to be required to ask that question. And just understand it's a little bit of a loaded question. You could be encountering any kind of these perceptions or a combination of them. And it might be good to give some thought as to which perception you have about death, because that's going to help you understand others. Okay, down to business of advance directives. An advance directive is a legal document that a person creates in order to plan for death. Okay? Plain and simple. That's it. It becomes effective when a patient is terminally ill and unable to communicate. So maybe you're wondering, what if a patient's terminally ill, unable to communicate this week, but next week they become better, they get a little better, and they're able to communicate? Well, then the advance directive is not in effect. But let's say that patient has a problem again and becomes unable to communicate, then it becomes effective again. So it's only effective when the patient is terminally ill and unable to communicate. And in that document is information that the healthcare providers are going to want. What kind of treatment does that patient want? Or who is the person that patient wants to make decisions for that patient when he or she is unable to do it. And that's your healthcare power of attorney. Pretty basic, really. You know, I became a nurse in 1984. Besides the fact that I am old, I want you, let's look at the date here, the Patient Self-Determination Act of 1991. So when I got my job in a nursing home, when I came out of nursing school in 1984, people didn't really have advanced directives on file. We didn't really ask them that question. And this is a relatively new concept, would you believe? In terms of the medical world, things change pretty slowly, except for the last decade or so. If a patient passed away in the nursing home, it was up to the nurse who found him to make the decision to start a code or not. There were not, very few people had a DNR, do not resuscitate order. Very few. Even the terminally ill ones often did not have that back then. So the nurse made a decision, and that decision was always, we were advised to always code everybody, unless they indicated otherwise. And that's pretty much what was done. So what happened was many very sick, very elderly, terminally ill patients were passed away, had CPR done, ambulance was summoned, they were sent to the hospital and pronounced dead on the scene, dead at the hospital, not on the scene, at the hospital, dead on arrival, I guess they call it. Or they would code them in the hospital for 20 minutes or so, and say, okay, let's call it and let's write out a death certificate. And then later on, research found that actually transporting very sick people to the hospital was more of a stress on their body. So it just became a very bad idea in the ethical sense to do anything other than to code every single patient unless they had a DNR on their bracelet or chart. So the Patient Self-Determination Act of 1991 was passed by Congress in order to protect the rights of its patients. And this law makes it clear that you have the right to make decisions about your medical care, including the right to accept or refuse treatment and the right to make an advanced directive. And the law requires healthcare facilities and agencies to discuss healthcare directives with the patient as they enter the system. So all those patients back in the 80s and before that who did not have any kind of advanced directives or DNR on their charts, they probably had some kind of perception of death or some attitude in their family that they didn't feel comfortable talking about it, or maybe they just weren't aware of that they had the right to make advanced directives or declare themselves a DNR. For whatever reason, Congress addressed this and requires the healthcare providers to inform the patients of their rights. So this was a pretty big change. And remember our Patient's Bill of Rights. And one of the rights in that Bill of Rights was the right to accept or refuse treatment. And treatment, coding a person, doing CPR and the paddles and all that, those are medical treatments. So people have the right to refuse those if they want to. So most hospitals, nursing homes, and home health agencies, as well as HMOs, are required by federal law to provide patients with information regarding the Advanced Healthcare Directive. And your pamphlet that we have from the Pennsylvania Bar Association as your handout today, that's one of those little pamphlets. Your employer is going to have some sort of pamphlet that you will give patients who do not have advanced healthcare directives. Okay, so in more detail, the institutions are required to give information about the healthcare advance directives, a written summary of them to the patient, as well as a summary of all their healthcare decision rights, and we talked about this with the patient's Bill of Rights, and all of the facility's policies with respect to recognizing and honoring advance directives. Healthcare providing institutions are required to ask if the patient has an advance directive and document that fact in the medical record and make sure that the patient gets you a copy of it. But even if they don't have a copy with them, it is their responsibility as a patient to get it to you. But you do document that in the record if you don't have the copy as well. Healthcare providing facilities are also required to educate their staff and community about advance directives. And the law provides that healthcare providers may never discriminate against patients based on whether they have an advance directive. Thus it's against the law for a healthcare provider to require a patient to have or not to have an advance directive. And there's another nice picture to look at. So the right to refuse treatment is covered in the 14th Amendment of our Constitution. And it is a dignity right. Our citizens have a right to dignity. And that is interpreted by Congress and the legislature, the state legislature, as the right to refuse treatment. So it is a very heavy, serious right in our society, not one to be taken lightly. Now, remember that Pennsylvania code we looked at governing the patient's Bill of Rights? I know you remember it. I bet you even have that memorized by now. But I'll read it to you just in case. Point 11 talks about the right to refuse treatment. A patient has the right to refuse any drugs, treatment, or procedure offered by the hospital to the extent permitted by law, and a physician shall inform the patient of the medical consequence of the patient's refusal of any drugs, treatment, and procedure. And that goes back to, that also covers the doctrine of informed consent, right? You have that memorized too, I know. Okay. I do want to go over a little bit of definition here about brain death. And because I'm sure you've seen it on television, you hear about it, oh, the person's brain dead, we're going to ask for organ donation, that sort of thing. A person is not diagnosed with brain death lightly. It is the diagnosis of brain death is written into the law under the Uniform Determination of Death Act. And this was drafted, it was written by a federal committee put together by Congress back in 1981. And the American Medical Association had some input into it, and the American Bar Association. So we have the legislators and the medical people and the legal people all working together to draft a legal definition of brain death. And it was drafted in 1981 and rapidly adopted by Pennsylvania in 1982. So it gives guidelines and then is further interpreted with protocols from the American Academy of Neurology to establish the actual standards for determining the brain death. So, make a long story short, a lot of people worked very hard to come up with a legal definition of brain death so that to provide uniformity of care to people with problems like this. So the definition is of brain death. It is the state of irreversible unconsciousness with complete loss of brain function, including the brain stem, although the heartbeat may continue. So we see an individual with a pulse rate, but absolutely no cerebral function. And I do not have the neurological standards memorized, but if you talk to any physician, they would be able to tell you that. But it is not something that one person decides. There have to be a team of physicians who collaboratively or individually evaluate the patient independent of one another, and each one individually reaches the diagnosis of brain death. And then once that is done, the team collaborates and may or may not proceed with requesting an organ donation. I don't know. Depends on the person's belief system and who their decision maker is. Okay, let's progress to our pamphlet by the Pennsylvania Bar Association, put out about the Advanced Healthcare Declaration, or what I call the short form. And it's a pamphlet that's not folded up. So I'm going to go through it with you. It'll be pretty brief. The first question is, what is an Advanced Healthcare Declaration? Well, we kind of already have a definition of that. It's a set of directions made by an individual to determine what kind of care they take when they are terminally ill and no longer to communicate decisions about their care. You can make it as general or as specific as you wish to, but it should be specific enough that people know what to do for you. It should describe the kinds of life-sustaining medical treatments and procedures you wish to be either initiated, continued, withheld, or withdrawn. And there's a rough copy on the other side of the brochure, the pamphlet here. Remember, and it tells you that Pennsylvania law provides that your desire to withhold or withdraw medical treatments for yourself is not considered suicide, euthanasia, or homicide. Those things we'll talk about later. But an advance directive is perfectly legal and above board. So who can make a health care declaration? Any individual who is of sound mind and at least 18 years of age, or who has graduated from high school, or is married, may make and sign a declaration. So this is pretty much the same standard of mental competency that we need for informed consent. But I'm sure you already figured that out. Anyway, the legal term for the person writing the healthcare directive is called the declarant. And the declarant may also direct another person to sign the declaration on his or her behalf. The two adults must witness the signing, but a person who has signed on behalf of the declarant, say somebody's paralyzed or has had a stroke and is unable to write or make an X anymore on the paper, and so the person who signs on behalf of that person cannot also be a witness, because the person is a signator. The living will does not have to be notarized, but it is best if you do. Okay, so next question, what should I include in my declaration? There's a sample on the back and we're going to go through that. They say you should consult with a lawyer. That's always a good idea, just to make sure you have the language right, but I think that a physician will be better to advise you about specific medical language. A lot of people don't have resources to go to a doctor and a lawyer to make their advance directive. As long as you don't ask for anything illegal, it should be honored. So, when is the declaration actually used? Remember, you have to be terminally ill and you have to be unable to communicate your needs. And the doctor must document that, both the incompetence to communicate your needs or decide and the terminal condition. If you improve, and you're able to communicate, then what you say is what you get. The advanced health declaration is no longer effective. But if you would lapse back into a coma and be unable to speak again, then the advanced health care declaration would be effective. So, is a doctor required by law to follow your advance directive? No, they aren't required by law to follow your advance directive. Let's say a person's in the hospital, they have an advance directive, but we have a husband, 3 children, and a sister of the patient, all of whom say that no, that's not what the person wants. That might be what she wrote years ago, but that's not what she wants. Well, the doctors are going to take that into consideration. But the doctors are the ones who will make a decision. If a physician or healthcare provider is unwilling or cannot in good conscience comply with your document, he or she must make every reasonable effort to assist in transferring you to another physician or healthcare provider who will follow your advance directive. Be sure to discuss your living will with all of your physicians so they will know what your wishes are. Because the bottom line is, it's between you and your healthcare provider, the declarant and the healthcare provider. And family members and friends and whoever else should not be imposing their beliefs, emotions, projections, whatever, onto the sick and or dying person. Okay, will the insurance be affected by the things you want in your advanced healthcare directive? No, they should not. If a person is pregnant, life-sustaining treatment, including nutrition and hydration, must be given to a pregnant woman who is incompetent and either terminally ill or in a permanent state of unconsciousness, regardless of whether she has a living will, unless an attending physician and obstetrician find that the treatment, 1, will not ensure a live birth, or 2, is physically harmful to the pregnant woman, or 3, causes pain to the woman which cannot be alleviated by medication. So as long as the fetus is viable, they must continue to provide nutrition and hydration and life-sustaining treatment. If an incapacitated pregnant woman is kept alive by life-sustaining treatment, the Commonwealth of Pennsylvania will pay her expenses, regardless of whether she has a living will. So the next question on the form, must I use the sample form that's on the other side? No, it is not required. It's suggested, it's recommended, it's a good start. And it comes right out of statute, and the other packet as well comes right out of statute. This is just a standard form that many people use, but it is not required. It can be any document. It can be handwritten, can be typed, so long as it is properly witnessed. And I'd suggest it be notarized, but it's not required by law that it be notarized. So the 3 most questions to ask yourself: what kind of things do I want to receive or refuse? What other instructions do I want to leave regarding my care? And do I wish to name a surrogate? Do we want to have another person making decisions for us? And who would that person be? Once again, they advise you to consult with your physician and lawyer. Think about it. These are tough things to think about. Coming up with an advance directive is not something you want to take lightly or casually. It requires a lot of heavy thought, and that's why lots of people don't have them. Okay, next question is, can someone else make decisions for me? Yes, the Advance Directive for Healthcare Law in Pennsylvania permits a person to name a surrogate and a substitute surrogate to make additional medical treatment decisions if the patient ever becomes incompetent and either in a terminal condition or permanently unconscious. They say, so you can name your brother, and your sister in case your brother is unavailable to make decisions for you. And that's good. I have encountered people who want to name like, oh, I want all my children, 5 of them to come together and make decisions. Well, what happens when you get more than 2 people? Once you get 3 and more, sometimes people get into arguments about what mom wants or what mom should get, and it gets to be a very difficult situation for all people involved. So while it's understandable that someone would want multiple family members to make decisions for them, it often doesn't go well. Let me just put it that way. So one person and one backup person, or they call it a substitute surrogate, these are going to become powers of attorney. We'll talk about that next. Is ideal, or 2, or people could make decisions. I one time did a will for somebody who named a person and wanted that person, if he or she needed any help, to talk to their religious leader of their church. And so that was a setup that he had. Let's see. And you can also limit the power of the surrogate decision maker. You can have them make decisions for you, or you can give that surrogate the power to make sure that decisions you made for yourself are carried out. You can control that degree of power. Okay, so what is a healthcare power of attorney? That's the document that authorizes the surrogate, someone as you name as your agent, to make decisions for you in the event that you're unable to do it yourself or to make your decisions known. It's similar to a surrogate in a living will, but this pertains to all medical situations. It's a broader power base, and the document can contain instructions or guidelines. And a healthcare power of attorney is a form of durable power of attorney and must be properly written to authorize your agent to make healthcare decisions for you. And this is when they say you should call in the lawyers and get more specifics. But as long as you know what you want, and that is put in the document, and it is properly signed by you and witnessed and notarized, then it will be honored, regardless of what the title at the top of the paper is. So it says, what should a person do once they have the signed documents? They've gone through all that hard thought process and decision making, and they've got people to help them, and they've done their document. Then what happens? It should be given to the physician, and it should be put onto the electronic health record. So anybody who needs to access that health record to take care of the person should be able to see a copy of that advance directive. It could be given to family members, friends, clergy, lawyer, and the surrogate, the person who's going to make decisions for you. So you should make sure that the provisions in that document are well known to all the people who need to know them. Another question here is, can I change or revoke the documents? Yes, it can be changed or revoked by the declarant or the patient, regardless of physical or mental condition, either in writing or merely by telling your doctor or other person that you don't want those things to go that way. You can change your power of attorney at any time by notifying your agent or healthcare provider of your decision. It's best to do it in writing and destroy the original documents, and to have a lawyer draft everything up for you. But like I said, you can write or have written for you your decisions once again and sign them and have them witnessed and notarized and revoke earlier documents. To make sure that's done effectively, you may want to have some kind of counsel. A lot of social workers this day and age are trained to do that sort of thing. And then it has, how can I locate an attorney? The Pennsylvania Bar Association does have a lawyer referral board that has lawyers who will charge reduced fees or no fees for certain kinds of assistance, and the phone number is on the pamphlet here. So if you look at the right side of this pamphlet where it says in the center, Advanced Healthcare Declaration, Living Will, and to the right, this little document here on this half of the page, that is an advanced directive. That is a sample. That's the whole thing. I know the writing is kind of tiny, and it just goes through what you want. And you can see, you make decisions about things like cardiac resuscitation. Do you want mechanical respiration? Do you want a tube feeding or IVs or a peg tube? Blood or blood products, surgery, invasive diagnostic tests, kidney dialysis, antibiotics. I mean, you, the person, has complete control over what care they get or do not get. What care they get or what care they do not get. As you can see, when I record myself, I'm just as perfect as always in the things that I say and do. Okay, so towards the middle of that half-page form, it says, I do or do not want to designate another person as my surrogate to make medical decisions for me. Name and address, if you chose one, give their name and address. The next line is about donating one's body. I do or do not want to make an anatomical gift of all or part of my body subject to the following limitations, if any. You can, you can donate certain things, kidneys, skin. They use skin for a lot of burn victims. And corneas. Corneas are really valuable to people. They can save sight of other people. Anyway, that's a whole different lecture, I think. But you can decide what, if anything, you want to donate of your body after you're gone. And then I know some belief systems strongly prohibit that, and some don't. And then here is, I made this declaration on the day and the year, the month and year, a place for the declarant to sign, a place for the declarant to put the address, lines for your two witnesses, and there isn't a space for notary, but if you would get it notarized, this form could actually be notarized in the little space down at the bottom. There's room for a seal. So that's it. In a nutshell, that is an advanced directive. That's all you really have to do. The form itself, like I said, is not a lot of work, but I will tell you that the thought process that goes into it is very emotionally and ethically laden. So it's a lot to think about. Moving on, let's look at that packet of papers that is the Durable Healthcare Power of Attorney and Healthcare Treatment Instructions in the Living Will. And this comes out of statute, Pennsylvania law books. And this is a little more detailed. It's not the question and answer format. It does give you more detail. And it has an actual, it's actually the third page of the document, but it's printed front and back, so it'll probably be the part 2. Could be the front of the second page. This is where it writes out the Durable Healthcare Power of Attorney. And this is where you would name your surrogate decision maker. And healthcare agent. And on the front of the third page, it has guidance for the healthcare agent, and that's optional. And you can put goals. And let's say your goal, a common goal, is to get comfortable, but not to sustain life unnaturally for a prolonged period of time. Well, that's pretty indefinite. So if you're just providing goals for a person, of course, they have to seek professional guidance as to how they're going to make sure that happens. So you want to be as specific as you possibly can. So, just above where it says Part 3 on the back of the third page, second paragraph down, it says, I therefore request that my healthcare agent respond to any intervening, other and separate life-threatening conditions in the same manner as directed for an end-stage medical condition or state of permanent unconsciousness as I have indicated below. So a person has a terrible, they have cancer and then they have a terrible stroke and they're still alive. Okay, they're saying, okay, I still want the same guidelines to be followed. Part 3 talks about healthcare treatment instructions in the event of end-stage medical condition or permanent unconsciousness. And this is the living will part. And so we go into more detail about being resuscitated or not, being ventilated or not, and all that. Tube feedings or no tube feedings. So, and the final paragraph before it says legal protection. And we are looking at the front of the 4th page. Healthcare agents' use of instructions. You initial one option only. Either the healthcare agent must follow the instructions to the T that the declarant provided in the document, or the healthcare agent can make decisions based on using this document as guidance. So that's where you can have greater control over what kind of power your healthcare agent has. And if a person decides just to give directions and not have another person involved, it just gives directions as to what they want done, then you don't have to have a healthcare power of attorney. You can just write a living will and say, this is what I want, give it to the doctor, and it should be honored that way. Okay, and then it has a section on organ donation and signature, 2 witness lines. Witnesses have to be 18 years of age or older, and a healthcare agent may not be a witness. If their name is somewhere in this document, then they can't also be a witness. You have to have 2 people as a witness. But in any lawyer's office or any office, social worker's office, there are plenty of people around who can witness the signing. It's not a big deal. And then the notarization page is on the back. Notice that it says notarization is optional, but it's a good idea. It costs a few bucks. And in a nutshell, that is your durable healthcare power of attorney. Now you've been through the whole process. Yeah, it probably isn't a lot of fun. It's not any worse than studying about HIPAA, but I will say that the documentation itself is not difficult, but it's the emotional issues behind it that get a person to the point where they can fill the document. That stops a lot of people. Moving on. This is a video I would like you to watch at this time. It is Facing Death in America. It's a documentary or docudrama about people who do not have healthcare directives, and that's why I include it into this lecture. This is what happens when we don't have healthcare directives and family members and friends and so forth are put into the spot of trying to figure out what we might want and what is best for us, and what happens to the individuals and the healthcare system as a result. And it is about 56 minutes long, and I would like you to stop this lecture and watch this video at this time. Okay, I would like to briefly review some bioethical issues about end-of-life decisions. I know, I realize that this is not the most fun lecture in the world. I call it Death Day in my class, but it's something we should know about, and you need to be comfortable with this because you're going into the medical profession, and guess what? This is what happens. When you deal with life, you deal with death. It kind of goes together. Okay, enough about that. Euthanasia and assisted suicide. I would like you to know what they are. I would like to tell you a story about Dax Cowart. This is a story that probably every physician who's trained in the United States studies in their ethics class in medical school. This is a story of a man who's still alive today. Let me get started before I give away the good part. Hate to give out those spoilers. In 1966, Dax joined the Air Force after high school graduation. By the way, Dax, I think it's a Swedish name. Anyway. So he became a fighter pilot in Vietnam. Served time in Vietnam, was discharged to the Air Force from the Air Force in 1973. So he's home from the Air Force. July 23rd, 1973, Dax is 25 years old. He gets injured in a fire and sustains severe burns over 65% of his body. What happened was he was working on somebody's truck in a field, and unbeknownst to him or anybody else, there was some kind of oil or fuel pipe under that field that was leaking some kind of flammable fumes. And Dax was working on a truck, and in the context of working on the truck, some kind of spark came off either his equipment or the truck itself, and the fire ignited. And he was severely burned out in a field all by himself in the daytime. So the first responder was a farmer who saw the flames and came running out to Dax in the field. And Dax asked the farmer for a gun to commit suicide right there on the spot. Of course, the farmer refused, called the ambulance came. He was taken to the hospital. He was transferred to the burn unit of the Parkland Hospital in Dallas, Texas, where he remains for 232 days. He sustained injuries in that all fingers were amputated. His right eye was removed. His left eye was sewn shut. He consistently requested to be allowed to die. Remember, he's 25 years old. Dr. Charles Baxter was head of the burn unit at Parkland. And he goes to Ada Cowart, who's Dax's mother, and Rex Houston, Dax's lawyer, as surrogate decision makers. Now, Dax Cowart did not have an advance directive. He was a 25-year-old adult in possession of his senses, competent to make decisions, but the physician chose to go to surrogate decision makers. Rex Houston pleads with Dax to continue treatment until the lawsuit is successfully settled. Okay, that would be the lawsuit against the oil company who owned the pipe that was defective, that made the fumes that caused the fire. So the lawsuit settled in 1974. Well, that didn't take very long. Of course, they knew they were liable. So on March 12th of 74, Dax was transferred to the Houston, Texas Institute for Research and Rehabilitation. So Dr. Robert Meyer, founder of the Institute, encouraged him, involved him in the treatment decisions. And after 3 weeks, resident mentions that rehab will extend over years. So he's told, look, it's going to take you years to become functional. So Dax didn't like this idea, and he refused wound care and stopped eating and drinking. Within days, his condition deteriorates terribly. A family meeting is called, and his mother Ada and his lawyer Rex attend, and at the meeting in which Dax takes active part, it is agreed to transfer him for aggressive care of his wounds. So with his consent, he's transferred to the John Seeley Hospital of the University of Texas Medical Branch in Galveston, where there are high-octane burn specialists who can evaluate and treat him. And he ends up being there for 14 months. Dr. Dwayne Larson does skin grafts and advises further surgery to maximize mobility and function. And Dax intermittently refuses. And at one point, Dax crawls out of bed, apparently trying to find a window to use in a suicide attempt. and a psychiatrist is called, and he is impressed by Dax's lucidity and rationality. So the psychiatrist says, yeah, this man is quite competent to make medical decisions for himself. Although he's competent and documented as being competent, Dax could not secure cooperation with suicide or discharge from the hospital. Well, this is back in the 1970s. Nobody's going to do an assisted suicide. It's still not legal in Texas, so that wasn't going to happen, and they refused to discharge him from the hospital. So his right to refuse treatment was basically denied to him. Dr. White secures changes in medication and treatment schedules, and Dax reluctantly agreed to cooperate with most of his treatment, but then would still refuse sometimes. And then in July 15th, 1974, Dax is transferred to the psychiatric unit of the Jenny Seeley Hospital in the University of Texas branch. So that's in July. And then 2 months later, September 19th, he's discharged to home from the psych hospital. First thing he does is attempt suicide, crawling out to a road near home where he lives with his mother, hoping to be struck by a truck. He receives treatment for depression, and then he enrolls in law school. He attempts suicide by medication overdose while in law school, and Dr. White recommends re-hospitalization to evaluate his insomnia and pain medications. So following 1 month hospitalization, Dax improves and continues to see Dr. White as an outpatient. In 1986, Dax got his law degree. He joined the Texas bar. He got married. Looks like he sued the oil company. He did have a lot of money that he got in the settlement. Then he got divorced. Then he remarried, and he now lives in San Diego. So now he's a lawyer, and he does public speaking about patients' rights. And the patient right that he purports the most is the right to refuse treatment. Because of his experiences, he is very strong advocate of the patient's right to refuse treatment. So he's making the most of the life that he has. There is a documentary out about Dax Cowart, and it is called Please Let Me Die. And I don't have that, and it costs a lot of money, so I wasn't able to actually get the documentary, but I do want you to be aware of his story. This is a story about a person denied the right to make decisions. Another case study I want to tell you about, which is a different perspective, and it's called Diane's story. Of course, we don't know her last name. This came to me from a website on the right to die. Diane's story. She grew up in an alcoholic family. As a young adult, she struggled with alcoholism, vaginal cancer, and depression. She sought help and overcame these challenges, redirected her life, and found happiness and success. Still reasonably early in her adulthood, she's diagnosed with acute myelomonocytic leukemia. The prognosis that was given to her was 25% survival, and that's with invasive treatment. Surgery, chemo, radiation, so forth. With no treatment, she would have days, weeks, or months left to live. So, she made an informed decision and chose to decline treatment. She decided to live the remainder of her life outside of the hospital, and made the decision with her family's support. As I understand, she had a husband and children. She had a son. She talked to different doctors, she talked to a psychologist, and she was a very well-informed young woman and made her decision. And she came to the conclusion that the best decision for her was to live her life at home without further treatment. So, as to her end-of-life experiences, she discussed with the physician end-of-life options if suffering became unbearable. And I think that's a very common fear, is people may not be so much afraid of death itself, but the pain and the suffering that they associate with it. So she wanted to have some control over that, over her death, in terms of the pain, the suffering, and maybe even the time of death if the pain and suffering couldn't be otherwise alleviated. So her physician recommended that she contact the Hemlock Society, which is a group that supports terminally ill patients and their right to die. I personally don't know anything about this society, but I'm sure it could be Googled if people wanted to know more. She spent time with her husband, son, and loved ones, and she spent time counseling other terminally ill patients on the right to refuse treatment. Now, her physician prescribed barbiturates for her sleeping problems, knowing, and the physician knew, that her intention was to use them for suicide if and when she came to the point where she could no longer endure her suffering. In the context of informed consent and teaching her about her medications, the doctor informed her of the dosage she would need just to sleep a night and the dosage that would cause her to die. So, sometime later, she began to experience the symptoms of the terminal acute myelomonocytic leukemia. Her life became consumed with bone pain, fatigue, fever, and weakness. She felt that the end was near and contacted close friends and family and said goodbye to them. She said goodbye to her son and her husband and took the lethal dose of the prescribed barbiturates and went to sleep. Her husband and son found her an hour later, having died peacefully in her sleep. And this is a story about a person executing their right to decline treatment and to manage their own death. So it illustrates freedom of choice, and this individual's choice was to alleviate the end-of-life suffering, a person's right to die, the importance of quality of life. And you know what? That concept is very different from person to person. And that's why people make their own decisions about how their life is to go. So as medical treatment advances for terminally ill, we have more whistles and bells and machines that will prolong life. But sometimes this creates a diminished quality of life. And so I guess the issue is finding the balance, quality and quantity. The physician's involvement in Diane's death ensured a safe and comfortable suicide. And the doctor is quoted as saying, "Diane taught me about the range of help I can provide if I know people well, and if I allow them to say what they really want. She taught me about life, death, and honesty, and about taking charge and facing tragedy squarely when it strikes. She taught me that I can take small risks for people I really know and care about. Although I did not assist in her suicide directly, I helped indirectly to make it possible, successful, and relatively painless. Although I know we have measures to help control pain and lessen suffering, to think that people do not suffer in the process of dying is an illusion." So, that is Diane's story, which gives, a little bit of life to the idea of choice of treatment. Now, going into that, I would just like to review some definitions. Euthanasia. This is on page 2 of Points to Remember about advanced directives. Euthanasia is from the Greek root words meaning good death, and it is the act or practice of ending the life of an individual suffering from a terminal illness or an incurable condition, as by lethal injection or by the suspension of ordinary medical treatment. And then there are different kinds of euthanasia listed there, which I won't go into detail about. Active euthanasia, passive euthanasia, voluntary euthanasia, and involuntary. And finally, there's a definition for assisted suicide, which is where a physician or other party provides the patient with the means to end his or her own life. Example, which is exactly what Diane's story is. An oncologist prescribes sleeping pills for a terminally ill patient and informs the patient how much many pills it takes to cause death. And the patient ingests these at a lethal dose at a later time and dies. So that really was an assisted suicide. As you can see, it's a really volatile issue. Everybody's going to have an opinion on it based on their belief system, and I wouldn't argue with anybody's opinion, because I think everybody, and I know, and it is legally everybody's right to make their own decision. However, I would like you to know that euthanasia, that is when a person, remember, euthanasia is the act or practice of ending a life of an individual. One individual ends another person's life. That is illegal in all 50 of the United States. It is legal in some other countries, but not in the United States. And assisted suicide is illegal in Pennsylvania, pursuant to Constitutional Statute Section 18, Title 18, Section 2505. Now notice that it says Title 18 in the beginning. Anything Title 18 is in the criminal statute. So it is actually, assisted suicide is a crime in Pennsylvania. And the law reads exactly, a person may be convicted of criminal homicide for causing another to commit suicide only if he intentionally causes such suicide by force, duress, or deception. And a person who intentionally aids or solicits another to commit suicide is guilty of a felony of the second degree if his conduct causes a suicide or an attempted suicide, and otherwise a misdemeanor of the second degree. I would like to know that physician-assisted dying, or they call it PAD, is legal in 4 states: Washington, Oregon, Montana, and Vermont. Those are the 4 states that provide that it is legal to do physician-assisted dying. And this is exactly what happened in the story, where the physician gave the patient the medications, and she decided when and where and administered them to herself. This is a big topic, and I don't know that much about it beyond what we're talking about here today. But if you go to this website, Death with Dignity National Center, you'll find a lot of proponents of the right of patients to make decisions to this degree. It's just a very big topic. If you have an interest, you can go there. Also, you can always Google any question that you have, and there's just volumes and volumes of information and opinions out there. And with all of that said, I would like to thank you for enduring this topic this day, and just think about it now. You've done all the HIPAA, you've done the death and dying, and it can only get better from here. Thank you very much.